Hi, I'm Dr. Sam Hazledine, and welcome to another episode of the Well Doctor series. Today, I'm really grateful to be here with Dr. Richard Egan to discuss the role and importance of faith and spirituality in healthcare. As a Christian myself, I've experienced the first-hand power of faith, of surrendering, and as a doctor, we only want the best for our patients. And we also must respect their beliefs and their worldviews. So there's an important balance which I'm looking forward to unpacking today. Welcome, Richard.
Thank you. Great to be here, Sam. Kia ora.
Awesome to have you here. Richard Egan has spent 25 years researching and working in the field of spirituality and faith in healthcare. He completed a Master's in Spirituality and Education and a PhD split between public health and general practice. I have long admired his work from afar, so it's a real privilege to be speaking with Richard today. Something that struck me, something that Richard shared with me when we were preparing for this call, was that only 20% of New Zealanders are religious, yet 80% of people who are seriously ill or terminal wish for some sort of spiritual care. And this to me makes total sense, and it highlights not only the importance but also the responsibility of doctors to lean in and to address this. It also struck me how underprepared many of us feel in this space. So that's why I think today's conversation is a really important one. So we're going to cover three main areas today. And we'll dive into these, have discussions about them, and I'm sure you'll find them really interesting, really illuminating. We're going to talk about the ontological issues or the worldview, which is considering how spirituality is part of a person's fundamental outlook on life. We're going to talk about patients' needs and their wants, and how we can address what their patients, especially those who are seriously ill or terminally ill, address their desires, address what they want, and give them what they need in terms of spiritual care. And then the third area we're going to talk about is our, as healthcare professionals, provision of care, exploring how we as doctors and we as healthcare workers provide spiritual care, both implicitly through our presence and explicitly through taking a spiritual history and understanding, the relevant literature, the ethics around this. And to me, when we're preparing for this, I'd never even heard the word spiritual history, present and complaint, history of present and complaint, all that sort of stuff. But spiritual history was something new for me. So I think this is going to be really interesting. So Richard, let's get into it. Let's start with the ontological issues and the worldview. How would you describe your own worldview, and how does spirituality play a role in it?
Yeah. So I think one's worldview impacts how one practices.
Mm-hmm.
So as a healthcare professional or, in whatever we do. And so I think it's important to think about, you might say metaphysical ideas, philosophical ideas. That's what ontology encompasses. Because it's in the background or the underpinning of what and how we do that. And spirituality is part and parcel of that.
Mm-hmm.
My personal spirituality, I guess, developed. I was raised a Catholic. I ended up in the seminary for a couple of years, trained as a priest, lost my kind of naive faith in the seminary. I'd say that I would situate myself now in this growing area of I'm spiritual but not actively religious. I guess I'm culturally Catholic rather than actively religious, even though my mother would like me to go to church probably. But I think that framing of how you see the world is really important. And what we're seeing is that one's understanding of beliefs, values, meaning, purpose, how you understand the world, existential understanding of the world impacts on what you do and how you do it. So that's kind of what I'm about. And that's been important for me professionally, but also personally. So I've continued to develop a spiritual practice, which I think is important for everybody.
I'm interested in that sort of, yourself, but also how we would, talk with patients. Because for me, very different pathway. Didn't train as a priest. For many years, considered myself spiritual but not religious, and then, but it was always searching. And it wasn't until, I found Christianity and developed a relationship with Jesus that it all came together and made sense. So it went from something quite ethereal to something quite specific. And I wonder if there's, with regards to patients and people going through serious or terminal illness, how important do you see that sort of, specificity, I guess? It's a sort of rather than just sort of general idea of spirituality.
Well, I think the reality is, as you say, about 20% of our population is actively religious. And that doesn't mean just Christianity, that's across the religions.
Yeah.
And what religion does, or a formal belief system does, is it gives you a framework to understand reality, a la on ontology. And
Mm-hmm.
that framework to understand reality situates illness, it situates suffering, it gives us a way to understand suffering. Because suffering
Mm.
can, as you know, as a doctor, and as all the doctors listening will know, that it's just such a radical, heavy experience that people have, whether it's from the hard challenges of childbirth to aging and dying. So I think the framework that one has through a religious lens gives one an understanding to make sense of that. But what I
Mm.
think is a more of a challenge is, say, the 80%, and I sometimes call them the forgotten 80%, because how do those people make sense of the world, particularly when things are going wrong? And we had big existential crises, COVID and, geopolitical problems in the world, and those challenge us existentially. But at a personal level, when we have something, that inevitable terminal diagnosis, 60% of us will die of heart disease or cancer, and that will take months or years. And it's a long time to think about these things. And if you've got a religious framework, you can kind of situate that. But if you haven't got a religious framework, or what I call a spiritual literacy to fit that within, how do you make sense of it? And I think this is why, in what some people call a post-secular, or even a post-religious age, that doctors and healthcare professionals have become more important in the spiritual conversation with their patients, because they're not coming to that situation of serious illness, death, and dying with a way to understand it. So they're going, "Hey doc, how do I make meaning of this? Why me? Where does this fit?" And jokingly, we now teach this in second, third, and fourth year at med school. Jokingly, I say that you are the secular priests of today as
Mm.
young doctors, and they'll go, "Oh my gosh, how does that work?" So we're in quite a different situation in the sort of 21st century, and this started happening. You think about the postmodern movement, you think about the movement of undermining truth, you think about the movement of people challenging authority at a mass level. This undermined those what we call meta theories, or like religion and belief and trust in medicine, etc. All these things are part and parcel of what can often be major spiritual distress for people who are seriously ill.
Mm. I mean, it's hugely important thing to consider, isn't it? Because as you say, and as I've experienced, once you have a religious faith and framework, a lot of things can be put in their place in terms of contextualized and made. Um, you get meaning, as you say, given meaning. And if 80% of people don't have that, yet 100% of people are going to face death at
Yeah.
some point, then it's a hugely important thing, isn't it, in terms of how you may help someone, or whether they, if they wanted, I guess, to develop something, or a part of their life that can help them through that stage.
Yeah, and I probably should qualify the 80%, because there's a lot of people that have developed meaning and purpose in their own way, a humanist way or a cultural way. So, for
Mm.
example, in New Zealand, we have a very strong Te Ao Māori renaissance. And what Te Ao Māori offers people is a framework, again, to understand reality, both from a creation story, rangi papa, etc., through to understanding tikanga and how one believes and behaves. So it's another framework for understanding who we are, and how we are to behave and act and understand things. But it's not easy, because even religious people, as you'll know, in times of stress, like, okay, I'm sorry, but you've got stage 4 cancer, which a third of us are going to experience, and you're going to die of cancer or whatever form that is. That challenges us massively. You know,
Mm,
why is God doing this to me? If I don't have a framework in terms of religious, what does that mean for me? And even people who don't have a religious framework still ask questions about what have I done? Who have I done it to? Who do I need to forgive? Can I be
mm,
forgiven?
mm,
Forgiveness is a huge issue. How do I deal with the suffering? What's going to happen to me after life? Well over 50% of the population believes in some form of afterlife, even though they're
mm-hmm.
not religious. So that's another component to this. Um, so there's a
It's
whole
a
lot
bit
of
of a
things
it's a
here.
bit of a juxtaposition, isn't it? Not religious, but believe in an afterlife.
Yeah, yeah, exactly. Yeah, exactly. And
Like,
the spiritual but not religious group, they have a whole host of range of different beliefs, and I think that that's the hardest one. Particularly, I think about
yeah.
young people, and we're doing some research with young people around this because if you haven't got a framework to understand this, you've got to work it out yourself. And
Mm,
there's some things that aren't particularly helpful. There's lots of disinformation. There's lots of things that take
mm,
people down all sorts of rabbit holes, as we know.
mm,
So yeah, I think there's some real challenges for young people whose spiritual and existential development, exploration, and growth is one really important, but two really difficult in what we
mm,
have in such a pluralistic society.
mm. It's definitely I guess if you look over the decades and comparing back to 100 years ago, it's I guess not is it harder? It's just much less likely for a young person nowadays to develop that sort of faith or that religious framework. What will they believe in, and to build that into their life. And this, I guess, society doesn't lean itself towards that these days, does it?
Exactly,
As much.
exactly, exactly. But inevitably they're going to ask those questions somewhere along the way.
Yes.
Yeah, so we're doing a study, or we're doing two studies with young people between the ages of 18 and 24. One people who've had cancer, and one people who've had mental illness, mild to moderate mental illness. And the reason we've chosen those populations is if you've had something big happen like that in your life, you're more likely to have thought about these issues. We could
Right.
we could do sort of a convenient sample of 20 young people who are the ages of 20. Um, and they might never have thought about these issues at all, and it would be a very
Right.
short interview. But if you choose someone who's had an experience of cancer or
Yeah.
mental illness or mental distress, which is probably at least 1 to 5 of them or more,
Mm,
it's fascinating actually what comes out in terms of what that means for them and also part of their recovery,
mm,
because spirituality is particularly important in different places on the medical continuum. So, for example, if you've got a cold and you go to your GP, you don't want them to ask about your spiritual well-being.
no.
Um, but as we talked about once earlier, if you're like Dr. Pat Farry in Queenstown, who was, a legendary GP there, he explicitly asked his patients, who he knew really well, he'd been there for years, when they were dying, about their spirituality. And he
Yeah.
was he was doing this years and years ago before we started to talk about this in the literature and the research.
Right.
So there's different times when it's important, serious illness, mental illness, terminal diagnoses, experiences of renal. So Rob Walker, who probably taught you,
Yeah. Hey, Professor Walker. Yes.
Professor Walker, another famous
Yeah.
medical professor here in the medical school, him and I did some research looking at nephrology and renal and spirituality. And what came out there is that if you've got a serious renal, I think they've got stages too, disease, you've got on average 5.4 years to live, something like that.
Oh
So it's a
wow.
it's a it's a long terminal
Yeah.
diagnosis.
Right.
It's a long time to think about what's going on. A
Yeah.
lot of those 3 a.m. moments when you're going to wake up and just go, oh my God, I'm going to die.
Yeah.
Even though I'm on, dialysis or whatever. And so what he says is and he's a practicing nephrologist as well, isn't he?
Mm-hmm.
Yeah. He says that they get to know these patients really well.
Mm.
They talk about some of these issues, but they really don't talk about death and dying and those big spiritual issues.
Mm.
And partly to do with our research, but it was also the international research. They've now put into the Australasian guidelines on, for renal guidelines, the importance of spirituality and religion for people in that process, which I
Mm,
thought was a fabulous,
absolutely.
upstream guideline policy approach as well.
Yeah. Well, I mean, you know, it can change everything in terms of someone's experience, can't it? Like,
Exactly.
it's not.
Exactly.
This is not a little improvement. This is a different world that they're living in if they really have faith. So let's talk about that second area, which is the patient's needs and wants. How do you identify? I guess there's a couple of parts to this. How do you identify if a patient wants to discuss spiritual or religious matters? And I guess a second part to that is, and if they don't, what role do we have in terms of encouraging them to?
Yeah. There's a lot into that second question.
Yeah, that's the tough bit.
Yeah. I guess the first thing is what we know from the research, and this comes from a JAMA review article in 2002, which was then further developed in a Lancet article. I looked at it again this morning. So this is pretty good science.
Mm-hmm.
Is that, as you said, about 80%, it varies between 69 and even up to 95% of patients with serious illness have spiritual needs.
Mm,
So the research is kind of in on that the majority of people with serious
mm,
illness or terminal illness have spiritual needs.
yes.
So that's one. Now, who and how that's addressed is a larger question.
Mm,
What we do in terms of teaching this now, and this is developing, but we say that one, they're important. Here's the literature of why, and here are some approaches to address that. I call it a spiritual care toolbox, is that
mm-hmm.
every healthcare professional, we argue, is a spiritual care generalist. And you guys know
Mm,
about generalists and specialists, so
yep.
you're a spiritual care generalist, and you need to know how to do some initial screening and history taking,
Mm,
of which you then need to know if you get to the end of your either time or your capacity, you then need to know how to refer on to a specialist, just like you would
mm,
do in any other
yeah,
medical
right.
area. Yep. And our specialists are our chaplains, spiritual care experts, which we can talk about them. They're really important. But how
Mm,
do you do that? Well, you have in your toolbox a series of questions, just like you do in any other area. One,
mm-hmm.
that you feel comfortable with, and
Yep.
two, that you've looked at are based on the literature and how we do this. And so I present some of the validated tools that have been used around the country. One's called FICA, and so we teach FICA, and lots of the students know FICA. And that's asking about faith and belief, how important that is, the community that you're connected to in terms of those faiths and beliefs, how are we going to explore that? And then what action do we need to take? Now, if that's a religious thing, there might be some things about blood, or there might be some things about, I think that, do not resuscitate is a spiritual question,
Yeah.
et cetera, et cetera. There's all those sort of things. So you can have an acronym approach, or you can have, is spirituality and religion important to you? You can be
Mm,
explicit as that. If it is, you can go down the line, but it has to be asked, because if you don't ask it, if you
mm,
don't give a patient and their whānau the permission to say something which often is what matters most to them,
yeah, yeah,
then you'll be missing a whole component to who they are.
yeah. Yeah, absolutely. I guess, as you say, that the 20% for who are religious, it's quite an easy answer. It's like,
Exactly.
yes, I'm a Christian, and so give me the pastor. Let's have that conversation. It's
Exactly.
the 80% that's going to be harder to navigate, isn't it? Where you
Yeah.
go, okay, so you're not religious. I guess how do you remain patient led? And I guess, again, another sort of tricky question is, and if you as a doctor have very strongly held beliefs, how do you honor the patient who may have very different beliefs from you?
Yeah. So I think that, and I've got a whole two slides that I think are important here in terms of what my teaching. One is how to talk about spirituality without using the S word, and two, the ethics of spiritual care.
Right.
So you can ask about spirituality by asking about what matters most to you.
Yep.
What is it that we can do for you right now that will make your life better?
Hmm.
There's kind of approaches into existential care. You
Right.
know, now you asking that question, they might not answer you, but it's going to put something into their mind about thinking, if they're not already thinking about it, because we know most people think about this. That will give them permission to explore it. They might not explore it with you on your round, but they might explore it with the nurse or ironically the cleaner or that person who
Yeah.
might be there for in that moment. We interviewed a cleaner recently and they have conversations with people about these things. I think the second thing is, you talked about being patient led. I think that integrity is incredibly important.
Mm.
You can look for all sorts of signs as you do signs and symptoms. If you see a cross or a Bible or, those sort of religious symbols, gives you an easy inroad to those things.
Mm.
But most people won't have that. So therefore, you've got to ask in a way that is open-ended and patient-led. And there's nothing worse that you can do ethically in terms of spiritual care than proselytizing. You can't say, as one GP in New Zealand did say, that the devil's
Yeah.
got his claws in you.
Yeah.
And then he was taken up before the appropriate
Yeah.
authorities. The other thing that I think in terms of ethics is knowing something about your own spirituality. So
Mm.
knowing something about your own spiritual beliefs and where you sit and fit in these things. Now, if you
Mm.
don't like the word spirituality, as some of my hardcore science people think about your existential intelligence. And, so what are your beliefs? Where do they fit? Where do they sit? And if you're asked, how are you going to respond to that?
Yeah.
How are you going to respond to one of your patients, which in one of our studies, we had a number of people say, Doc, can you pray with me?
Yeah.
What's your response to that question? And there's a whole range from, yes, you'll pray with them because you're comfortable with that, to please pray and I'll just stand here quietly, or I'll go and get Mary, the nurse, who's a good prayer. There's a whole lot of options there, but we need to be aware and have thought about these things, just like you have training and everything else. How do we do good spiritual care? Thinking about this before it comes up in the clinical context.
Mm. Yeah, it's a great point, isn't it? Not being caught out with because we're talking about the big questions here,
Exactly.
and this is meaning of life stuff, and so you don't want to be sort of making it up on the fly, I guess, do you?
Exactly. And I mean, we have looked at what are the barriers to spiritual care and healthcare, and the barriers are often things like training, competence, and confidence. And
Hmm.
if you had some training, we know that you'll be more likely to do the spiritual care. Now, there's
Mm.
the other ethical issue here is what if someone brings up something huge and says, "Hey, listen, you know, I'm." It's like that, that classic question of, I'm going to kill myself or I'm hurting someone. What do you do with it? You think
Mm.
about a lot in bioethics. It's the same with spiritual care. If you ask these questions, you need to know what to do with them.
Yeah.
And time is always a massive issue. We know that particularly within hospital or primary care, not so much in hospice care. But what do you do in a busy ward if something like that comes up because you've asked the question?
Yeah.
Because
Yeah.
Associate Professor Richard Egan said in fourth year that's what we should be doing. You know, but I also say when to refer on, and you have on speed dial that spiritual care expert
Yeah.
who can come and sit down for an hour as opposed to
Yeah.
your 5-minute round,
Yeah. Yeah.
and then unpack those things.
Yeah. And I guess maybe also part of it is knowing when to ask the question as well. Maybe on
Exactly.
morning rounds is not the time.
Exactly. Exactly. They say that of GPs actually. So it takes 10 GPs 10 years to work out the real nuts and bolts. Then eventually they become that intuitive clinician
Right.
where they can really ask about those questions and know when to ask about those questions.
Ask at the right time.
Yeah. Yeah.
So I guess thinking about, us as healthcare professionals, as doctors providing that care, I mean, one thing that comes up for me just now is, what if you find yourself in a position where a patient's approach or belief is like very contrary to yours, and you find yourself like in a position where you're really uncomfortable with, I guess, how they want to approach it. Like, what do you do in that situation? Because, faith and religion is, I mean, it's often a very, very strongly held belief.
Mm.
And if you believe something, it means you don't believe the other thing in certain, some things. So what do you do in those situations where you really find yourself on a very different place, in a very different place from the patient?
Mm. I mean, the bottom line is you have to be patient led. And
Mm.
now that could cause moral distress,
Right.
and so there's examples of that. For example, there's two obvious examples of abortion and assisted dying. So
Right.
we have doctors and healthcare institutions in New Zealand who choose not to be part of either abortion or assisted dying,
Yeah.
and these are major, I think, spiritual issues.
Yeah.
But the ethical approach to both of those things, and I've got a HRC project that I'm working with around assisted dying and evaluation of that, which is a real challenge for me, is to, one, be really clear, aware, and transparent about where you come from.
Mm.
And, I know a psychiatrist in this hospital who's so anti-assisted dying. He's very clear and say, hey, listen, I can't even have this conversation, but I know who can have this conversation.
Right.
And so I'm sorry, I'm just, this is not part of the care that I'm going to be able to give, but you need to be able to sort of refer on. And that's exactly the
Mm.
same. I know GP, anti-abortion can't be part of her particular practice, but she
Mm.
has to ethically to look after that patient, know when and how to refer on.
Mm. I guess a belief to hold, I was thinking about this out, as it comes out, a belief to hold is, faith has to be chosen.
Yeah.
So,
Not
if you,
imposed. Yeah.
exactly. So if you're sitting there going, you can't force something on someone, can you share your perspective?
If it's asked.
If
If it's
it's
asked.
asked, okay.
Absolutely, yeah. And depending on the context, it will be. I've talked to
Yeah.
many, many hospice healthcare professionals,
Yeah.
from palliative care physicians through to the nurses and the OTs. And there's often contexts where they're asked about those things.
Right.
So, I've been thinking about these issues and, what do you think?
Yeah.
And
Yeah.
that's when you've had to have some thought about that, but rather than the
Right.
spontaneous, shit, what do I think?
Yeah.
I've been
Okay.
so busy in my life,
Yeah.
learning about anatomy or whatever, et cetera,
Yeah.
that I haven't thought about these things. So I guess what
Mm.
we're doing is we're not saying that spiritual care is the only, is so important that you don't have to stop the blood. My sister's an ED doc and my niece
Yeah.
is a ICU registrar.
Right.
Both of them will first stop the physical
Yeah.
pain and the blood, but then there'll be some context. Even Joanne, my sister Joanne, who works in ED, there's times when she'll sit down. She has a little bit longer, than when she was a GP. She'll sit down and with a dying patient, and talk about some of those big issues in life because she's got a natural way, and her and I've been talking about this for years. So it's
Right.
something that she will personally do. And my registrar, my ICU registrar, niece, she saw 60 people die in the first half of the year last year.
Oh, wow.
So
Wow.
death and dying is just part and parcel of their
Of
life.
course. Yeah.
So of course spiritual issues come up.
Yeah. Yeah.
That's part of those, as you say, these are the big questions that happen,
Yeah.
when those things are happening in life. Rod McLeod, actually, did he teach you? He was a professor of
Yep.
palliative care.
Yep.
He said that again, after we deal with the physical pain, the most important issues for dying people are existential and spiritual.
Absolutely.
And I've never forgot that. And I think that's some of the basis of this work.
Mm. It's, I mean, my belief is that's not just when you're terminal.
Yeah,
They're kind of
precisely.
they're ultimately the most important things anyway. Yeah, it's a really interesting one for me, sort of sitting there thinking, I guess what you said before is, sometimes you have, I guess, as the physician, as the healthcare provider, you have to own your discomfort, don't you? Like
Yeah.
you can't try and unload, our job is not to emotionally unburden ourselves on the patient.
Yeah, exactly. I interviewed a senior oncologist, and one of the things she said is that there's two things we don't do very, very well, and that's sexuality and spirituality,
Right.
because we're not that comfortable with them ourselves.
Gotcha.
I've never forgot that either. I thought that was, so you're right about that level of comfort. And that, again, that's why we need training. This is a pet peeve. I think every year you have to have some updating about CPR as part of certification. Imagine having every year or a couple of years having some kind of updating about spiritual care.
Yeah, sure. Sure. I mean,
Yeah.
spiritual care probably works a lot more than CPR does. So,
Yeah. So there's
um,
a gap in the market there, Sam, for you about spiritual care.
there is a gap in the market. Like, I mean, if anyone's listening and has had no training in spiritual care, which is probably a lot of people. I mean, I know we had none when I was at university, which in fairness was a while ago now.
Yeah.
And it's so good that you get to engage with, with this generation of doctors, I think, that are coming through now. And even my generation, it's not the old school. People want to do better. They want to do well by their patients. They're open to new ideas and open to healthcare and medicine evolving. If someone's listening going, yeah, I'd like to do better, like what's a simple sort of tools, frameworks, questions that you could give them just to make a start? And then I guess also beyond that, where to read a bit more.
Yeah, I think two places to go. Professor Christina Putowski at George Washington University in Washington, D.C., she's kind of led the medical training of this around the world. She's a palliative care physician and professor,
Right.
and has fabulous resources, visual, and she's written all sorts of books and papers. And then Harold Koenig, who's a epidemiologist, psychiatrist, and the world leader on this in terms of spirituality, religious care. He's at Duke, and he has some of the best stuff as well. So between those two, you can't go wrong, as a medical professional. Hey, if anyone wants any papers, email me. I'll send you all sorts of things. Happy to share. And we have thought about some training as well for postgrad medical
putting
training
it together.
Well. Yeah.
And so, I mean, so just what would be, just take us through sort of, a few questions that if someone's just listening and doesn't, hasn't been off to do the research, like how would they conduct this spiritual history, and then, next steps for them to kind of take it forward? I mean, you talked about referral, but yeah.
Yeah. So the standard poor practice in our hospitals is, are you religious? Yes, no. What denomination? Do you want to see a chaplain?
Okay.
So there's three questions that narrow it down, that pretty much we miss most people, in terms of spiritual needs.
That rules out the majority.
Yeah, it rules out the vast majority. So if we can ask those questions that I mentioned earlier, whatever's comfortable with you in terms of, is spirituality or religion important to you?
Yeah.
What are you connected to? How is it going to affect your care? How can we do this better for you?
Yeah.
At a very simple screening, history-taking level, and include that in our notes so that it's ongoing. So just like you check blood pressure regularly, these things change. When there's a massive study that just came out of Denmark, and it talked about spiritual needs changing over the cancer trajectory.
Sure.
If we don't ask about it at different points in the cancer trajectory, we're going to miss those needs completely.
It's a good point. It's not just a one and done up front, is it?
Exactly.
It certainly might, as you say, you might sow a seed up front, but then when you're getting closer to the end, things may change quite considerably.
Massively.
So continuing to ask that's a really good point. I mean, if I was a junior doctor now, I just, I think it'd be build it into the first, upfront history.
Exactly.
You've got your history of complaint, medical history, spiritual history. Just put it in there, and then you can start to be a role model in terms of other people looking at it as well who may not have thought about it, and the nursing staff or the junior doctors or even the senior doctors may look at it and go, oh, that's actually a really important thing to be asking, isn't it?
It really is. And it's already in some places. So the New Zealand ACP, the Advanced Care Plan, has 3 questions about spirituality.
Right.
Awesome.
Yeah.
The HIPs, the health improvement practitioners that are now in many primary care organisations, they cover 75% of New Zealand now, these HIPs.
Wow.
Yeah, I was surprised too. I interviewed one recently, and they use a tapawhā approach. The work from Mason Jury from 86 on has changed the way we think about health. So now these young people who I teach in med school, when I say, how do you understand health and well-being? It's physical, mental, social, and spiritual. With them out, because they've learnt from the health and PE curriculum in New Zealand, they've learnt about that tapawhā model.
Yeah.
Tapawhā. So we now use that model in all sorts of things, and many clinicians, as I say, like the HIPs, they include spirituality in their assessment, though and this is early findings of our research, so this isn't published yet, but it will be, it does vary depending on that person's training. So you might have an assessment tool, but if you don't really know anything about spiritual care, it's really
Sure.
difficult to talk about it.
Yeah. Or if you've done no self-reflection or
Exactly.
no
Exactly.
personal exploration of what do I believe and what do I think happens and who do I believe in and how do I show that belief? Like if you haven't done all
Exactly.
that, then you're kind of just skating across the surface, aren't you?
Exactly.
Interesting. So, I mean, it probably brings us to somewhat of a close because when we were preparing for this, you said something that really struck me. And you said, while there is a lot that we can do while we age, we can eat well and exercise and all this sort of jazz. There's a point where we just said we're going to deteriorate. We're all going to die. And you said that, whilst the physical can deteriorate, we all have the opportunity to grow spiritually and to grow in our faith. So I guess to any doctor listening who, I mean, if you're in the 20%, probably well on that journey in terms of you have faith, you have a religion. But if you're in that 80% who's a bit more sort of, yeah, something, but I'm not quite, I haven't really done a lot of time thought. And, we as doctors know that a lot of us sit in that very scientific, very physical world model. How would you encourage, doctors, anyone listening to grow in their own faith?
Yeah, I would say faith and spirituality because a lot of doctors do respond negatively to me when I talk about faith.
Okay.
You know, I mean, New Zealand's fiercely secular, and
Yes.
I use that word consciously, fiercely
Yes.
secular. So I can talk about faith with people who have faith, but people
Yeah.
who don't have faith, they either like to talk about spirituality or maybe even their, as I say, existential
Yeah.
or meaning-making capacity.
Yeah. Okay.
How is life meaningful? I guess I would say, and a lot of doctors have thought about this, when you actually sit down and eventually get down to it, they've thought about having the examined life. The unexamined life is not worth living.
Yep.
Is increasingly we're showing that's true, and that's true
Yeah.
for all of us, including doctors. So
Mm.
I would say take those opportunities to really have the examined life, and what that needs is space and
Mm-hmm.
some kind of spiritual practice.
Mm.
I'm a very strong believer that every one of us, every human, doctors included, need to have a spiritual practice of their own.
Mm.
And if you're within that sort of 80%, it's working out what that spiritual practice is for you.
Mm.
And we know that that spiritual well-being is about connection. It's
Mm.
about connection to self, that sense of identity and belief, connection to others and that kind of community and whānau, connection to nature, land, sea, however you want, connection to creativity, art, etc., and connection to the transcendent, something outside of yourself, something bigger than yourself.
Mm.
So developing connections for your
Mm.
spiritual well-being is critical.
Yeah. And I guess I'm thinking about if young people listening, I thought that was really interesting. You're fiercely secular. That's a interesting use of words, but
Mm.
very true. You think about, say, American athletes, they'll get up and say, thanks, Jesus.
Yeah.
And as a Christian now, it's not as comfortable to say that in New Zealand, is it? It's
That's
like it's
right.
okay to talk about God, it's okay to talk about the universe. When you start saying Jesus,
Mm.
some people, as you say, will turn away and say using the word faith or spirituality. And I guess thinking about people exploring their own spiritual practice, being open to that evolution as well, and keeping looking for where you resonate, because
Yeah.
I've changed over my life, and when you find what resonates, that's when it's that's
Yeah. Patient satisfaction surveys are better when doctors connect with their patients, and connection is about what we call that implicit, compassionate connection. So you
mm,
can be an incredibly busy clinician
yeah,
and still do that implicit spiritual care by your compassionate connection, by being
right,
present and by being aware and intuitive and kind of
mm,
that connection. So you know you can do good spiritual care without a religious framework.
yeah,
but there still is something there about being aware and competent in this area. And we can't do that if we haven't thought about it. And
Yeah.
as I say, maybe some training and thinking about it carefully.
Yeah, well, I think that's a great place to leave people with is, how we show up matters,
Yeah,
and also, as you say, what we discuss and how we, I guess, gently, um, and with empathy, help patients go on the journey that, could be the most important one in terms of that in those final stages of their life or their, life in general.
yeah.
Brilliant. Well, thank you, Richard. As I said, I've admired your work from afar for a long time, and you've been really looking forward to this discussion, and it's been brilliant. So, thank you.